Assalamu alaikum, dear students. Today we are going to discuss sexually transmitted infections, and I would like to start with the anatomy of male urethra. Male urethra is divided into four parts according to the anatomical site. First, it passes through the prostate. This part is called prostatic urethra, in which ejaculatory duct opens in the posterior side. After leaving the prostate, urethra passes through pelvic diaphragm or levator ani muscles, and this part is called membranous urethra. After this, it passes through the root of the corpus spongiosum. Root of corpus spongiosum is called pulp, and this part is called bulbar urethra, and the last part is called penile urethra. Covering epithelium changes through the pathway through the urethra from transitional epithelium in the prostatic urethra to stratified squamous epithelium at the end or near the meatus, and in the middle epithelium is columnar epithelium. First group of sexually transmitted infections, we call it urethritis, and the patient presents with urethral discharge. So the presentation is urethral discharge. Urethritis is divided into gonococcal urethritis or non-gonococcal urethritis. Gonococcal urethritis is caused by Neisseria gonorrhea. Neisseria gonorrhea is a gram-negative cocci. It can be transmitted through sexual intercourse and or by indirect route, what we call through vomits. And the last way is what we call ophthalmia neonatorum, and this happens when a carrier female with gonorrhea, it transmits the organism to the eye of her offspring through vaginal delivery, and this we call causing ophthalmia neonatorum. Incubation period of gonococcal urethritis caused by Neisseria gonorrhea is 3 to 5 days or 2 to 5 days. This is the period from the sexual intercourse that transmits the disease to the presentation of the patient with urethral discharge. Urethral discharge can be described as white or yellow or green discharge with large amount. We call it profuse discharge. Profuse urethral discharge. That happens or starts after 2 to 5 days from the sexual intercourse. Usually, patient presents with this complaining of urethral discharge. As we see in this picture. Here is another picture for the discharge in male or female. Gonorrhea usually targets columnar epithelium. So, as we told before, in the male, the main target is the urethra. However, in the female, the main target will be either the female urethra or cervix. Endocervix is covered with columnar epithelium, and it is a possible target for Neisseria gonorrhea. Let's take a look at this figure again. If the infection is left untreated or with delayed treatment, the organism may spread to other sites to cause what we call complications. So as the infection is here in the anterior urethra, it may spread to the posterior urethra and may affect the prostate, causing prostatitis. And here the patient will be presented with pain in the perineum, the site of prostate. Prostatic acini is also covered with columnar epithelium. Patient may suffer from seminal vesiculitis. Organism may travel through the vase, causing epididymitis or epididymoorchitis. Infection also may spread to the bladder, causing urgency, frequency, and signs of bladder irritation. This is the figure again. The organism, as we told, may travel to the posterior urethra, affecting the prostate, causing prostatitis or seminal vesiculitis, or travel through the vase, causing epididymitis and epididymoorchitis, may enter the bladder with signs of bladder irritation like frequency, urgency. In order to diagnose the case, usually the patient is diagnosed clinically. However, we can use other confirmatory methods like what we call direct film or smear, where we take a part of the discharge and stain with gram stain to see this figure, what we call gram negative intracellular kidney-shaped diplococci. It's gram negative cocci present inside the pus cells. That's why we call it intracellular kidney-shaped diplococci. Other methods, we could use agar, chocolate agar, or Thyre Martin agar. This media used to help the growth of Neisseria gonorrhea. So direct film stained with gram or smear. Then we can confirm using chocolate agar or Thyre Martin agar as culture media. As regards the treatment, the first line treatment for such a case is ceftriaxone, which is third generation cephalosporin. Ceftriaxone, 250 milligram single dose, single intramuscular injection, or spectinomycin can be used, 2 grams single intramuscular injection. Quinolones also can be used for such a case. This is for the first part of urethritis, what we call gonococcal urethritis. Other organisms can cause urethritis, and that in this case we call it non-gonococcal urethritis. Non-gonococcal urethritis share the common features of gonococcal urethritis with the same presentation. However, events go slowly. Incubation period is longer. Instead of 2 to 5 days, it takes 2 to 3 weeks for the discharge to start. The discharge usually differs. We can describe it as scanty, of little amount, scanty mucoid urethral discharge. Scanty mucoid urethral discharge. As regards the complications, all the complications can happen. Patient may be presented with prostatitis, seminal vesiculitis, epididymitis, orchitis. And remember that incubation period is longer, 2 to 3 weeks. instead of 2 to 5 days in gonococcal urethritis. Non-gonococcal urethritis can be due to Chlamydia trachomatis or Mycoplasma species. And here the treatment differs. The treatment is different. First line treatment is azithromycin 1 gram single dose or tetracycline like doxycycline 100 milligram day and night for 14 days. Usually azithromycin, when you start to study, you'll find that azithromycin is also present as line of treatment on gonorrhea. In gonorrhea cases, we give azithromycin to treat chlamydia or mycoplasma if there is a co-transmission of infection. Azithromycin by name is not used for treatment of gonorrhea. However, we give it for patients with gonorrhea with the first line, as we told before, ceftriaxone or spectinomycin. We give azithromycin with them in order to treat the co-infection. Last disease in the urethritis group is trichomoniasis. Trichomonas is not a bacteria. Trichomonas is a protozoa. Usually lives commensal in female vagina because female vagina is anaerobic media, contains source of nutrition, which is glycogen, and both help Trichomonas for living. So Trichomonas vaginalis is usually a commensal organism living in female vagina. However, at some times there is a flare and multiplication of organism to give or to lead to that leads to symptoms. Symptoms is usually a vaginal discharge. It can be described as frothy, offensive discharge. So it presents with frothy, offensive discharge, and the patient may suffer also from vaginitis, cervical affection. Cervix can be seen spotted, and it's called strawberry cervix. So the patient presents with offensive, frothy discharge, signs of irritation, vaginitis, cervicitis, what we call strawberry cervix. Trichomonas vaginalis can be treated with metronidazole. We can start with 2 gram metronidazole single oral dose, metronidazole or tinidazole. If there is a recurrence or patient is not cured, we can use the second line protocol, 500 milligram day and night for 1 week. Trichomonas is a motile organism that this motility can be used in the diagnosis with dark ground microscope. Also, Trichomonas can be cultured, which a smear can be taken and stained with Baba Nicola stain. Not important the name of the stain, however, so Trichomonas is a commensal protozoa, lives in the vagina. It can sometimes be pathogenic, leading to discharge, offensive, frothy, leading to vaginitis or cervicitis. Can be diagnosed with dark ground microscope or stained or cultured, and the treatment is metronidazole, 2 grams single dose, or the second line 500 milligrams day and night for 1 week, metronidazole or tinidazole. By this, we finished the first group of sexually transmitted infections, what is called urethritis, and the patient presents in this group with discharge. For the second group, the patient presents with genital ulcer. The most important of diseases presented with genital ulcer is syphilis. Syphilis is caused by an organism called Treponema pallidum, which is a motile organism. Syphilis is the disease with multiple stages, 3 or 4. Primary syphilis, which is the genital ulcer presented. Secondary syphilis with a variety of systemic and generalized symptoms, and tertiary syphilis, and with another stage. That's why some people tell that syphilis is composed of 4 stages. So primary syphilis, secondary syphilis, latent syphilis, and tertiary syphilis. When the organism enters through the skin barrier, it usually multiplies locally within the arthritis obliterans, leading to an ulcer. This ulcer is called chancre. This is the first stage, the chancre stage. This ulcer, how can we describe this ulcer? Some, usually single ulcer, site, usually genital, 90% of cases are genital, 10% are extragenital. Extragenital in oral mucosa, lip, breast, hand. However, 90% is genital. Usually rounded ulcer. In order to fulfill the description of ulcer, you have to describe the floor, base, edge, and margin. For the floor, as we can see in the figure, in the picture here, clean floor, firm base, sloping edge, and to end your description or to fully describe the ulcer, you must describe the lymph node. As regards the lymph nodes, can be described as firm. The lymph nodes are firm, enlarged, discrete. Discrete, that means that every lymph node is enlarged but separated from the other lymph nodes, not matted together. So the lymph nodes are enlarged, firm, painless, and discrete, present in the draining area. If the chancre is present in the genitalia, so the lymph nodes will be inguinal. If the chancre is present in the hand or the breast, the lymph node will be axillary. This is the first stage, and it usually happens due to local multiplication of the organism, which is Treponema pallidum. After a while, the multiplication is more severe, causing bacteremia, so we will be transmitted. Let's take a look at these ulcers. This is a chancre happening in the lip, another chancre in the tongue. Then after a while, up to 6 weeks, the patient will be presented with what is called secondary syphilis. Secondary syphilis should be described as a systemic disease. The patient presents with rash, affecting all over the body. The rash can be described as bilateral, symmetrical, affecting palm, sole. The rash can be macular. Macule is just a discoloration. Papular, papule is an elevated lesion, but never causes vesicle. The secondary syphilis rash never causes vesicles. As regards the lymph nodes, there is generalized enlargement of lymph nodes. Generalized, all body lymph nodes are enlarged with the same criteria we described before in the chancre. Firm, discrete, painless enlargement of all lymph nodes of the body. The patient usually or may have systemic symptoms. Fever, anorexia, malaise, may have systemic affection, nephritis, hepatitis, even meningitis. The secondary syphilis usually happens, as we told, due to generalized spread of the organism, affecting the whole body. Mucous membrane may be affected with mucous membrane patches or linear ulcers called snail tract ulcers. This is the second stage that usually happens up to 6 weeks after the first stage. The first stage, as we told, is called chancre. Then the patient usually enters a stage what is called latent syphilis. In latent syphilis, the patient usually is asymptomatic. The patient is asymptomatic. However, he may be infectious. Serology may be positive. So in latent stage, clinically, the patient is asymptomatic. However, investigations can detect the case. Patients may stay after entering the latent syphilis. The patient may be cured, spontaneous cure, may stay in the latent syphilis, what is called persistent latent syphilis, or may progress to a more or the case may progress to tertiary syphilis. For the tertiary syphilis, what is in our scope is benign tertiary syphilis or gamma. Gamma is a hypersensitivity reaction that's unknown why it happens due to the minute amounts of syphilitic antigens present. Gamma usually is a nodular lesion that usually may ulcerate. Gamma can happen inside organs or on the skin. For the skin, the gamma usually causes an ulcer, what's called gummatous ulcer. Gummatous ulcer can be described as firm floor, firm base, wash leather slough floor, punched out margins. However, the most important that gummatous ulcer doesn't show lymphadenopathy, no enlargement of lymph nodes. That's why, because gummatous ulcer usually don't contain organism, just minute amounts. No organism can be detected, so the lymph nodes are negative. How can we diagnose a case of syphilis? First of all, as we told before, the causative organism is called Treponema pallidum. Treponema pallidum is a motile organism, so it can be detected using dark ground microscope, as we just said while discussing trichomonas. But the cornerstone for diagnosis of syphilis is serology. Serology for syphilis is divided into two groups. The first group, it's called non-specific tests. From these non-specific tests, it's important to know two tests. VDRL stand for Venereal Disease Research Lab, or RBR that stands for Rapid Plasma Reagin Test. These tests give high sensitivity, however low specificity. So usually we start by non-specific tests. It's non-specific because other causes can make it positive. Like what? Like lymphoma, leukemia, autoimmune connective tissue diseases, for example. In order to confirm, we usually do the specific tests. The specific tests in our scope are treponema pallidum heme agglutination test, fluorescent treponemal antibody test, treponema pallidum immobilization test. These tests are used to confirm the positive result given by VDRL or RBR. Recently, with the update of new specific tests, the pathway may be reversed. That's what we call reverse pathway. It's not important to know. However, the traditional is that we start with non-specific tests, VDRL or RBR, then to confirm with a specific test, fluorescent treponemal antibody test, treponema pallidum heme agglutination test, treponema pallidum immobilization test. In order to treatment is divided into the treatment of early syphilis or late syphilis. Early syphilis is the events happening in the first 2 years. That includes the chancre, the secondary syphilis, and the part of latent syphilis in the first 2 years. The part of latent syphilis after 2 years and the tertiary syphilis is called late syphilis. First line treatment for us is benzene penicillin, what's called long-acting penicillin. 2.4 million dose, single dose, million unit, single intramuscular dose. Or tetracyclines for 15 days. In cases of late syphilis, benzene penicillin is given for 3 doses, weekly dose, 3 weekly doses. Or tetracyclines can be used for whole 30 months. The last thing we can discuss today is HIV, human immune deficiency virus. Human immune deficiency virus. Human immune HIV is part of a family that's called reverse retroviruses. Retroviruses is called like this due to the presence of an enzyme called reverse transcriptase. These viruses need to do what is called integration, that it integrates its genetic material into the host DNA. These viruses is an RNA virus, so it can't directly integrate its genetic material in our DNA. So it uses the reverse transcriptase enzyme to form another template of DNA that can be integrated. That's why it's called retroviruses. HIV can be transmitted like any blood-borne disease. sexually, and as any other blood-borne disease, intravenous drug abusers, blood transfusion, etc. The virus targets the cells with CD4 positive, the most important of which is T helper cells, causing, causing a gradual destruction and decline with the resulting severe immune suppression. After infection, 50% of the patients may suffer from acute stage. Acute stage, it can be described or can be similar to infectious mononucleosis with fever, skin rash, hepatosplenomegaly, lymphadenopathy. This is the acute stage. It doesn't happen in all patients, only in 50%, and usually show spontaneous resolve. After it resolves spontaneously, the patient is in asymptomatic stage for years. This asymptomatic stage is because the T helper cells is still able to maintain immune functions. However, the patient is infectious at this stage. After years, with gradual decline of CD4 count or T helper count, the immune suppression starts in the form of opportunistic infections and maybe some malignant diseases. In order to diagnose a case of HIV, you can search for antibodies. You can search for one of the disease of the HIV antigens, what's called the P24 antigen. Of course, the cornerstone for diagnosis and follow-up is polymerase chain reaction, PCR. And to follow up the patient, you can measure the CD4 count, T helper CD4 count. So CD4 count is not a diagnostic test. It is usually used to follow up the patient. It's usually used to follow up the patient. So the CD4 count is not a diagnostic test. However, it's used for follow-up of the patient. HIV recently can be treated. However, it's not a final or curative treatment, but it is used to control the viral replication and the viral progress. All of these treatments are lined under what's called highly active antiretroviral therapy. Highly active antiretroviral therapy is designed the treatment to stop every stage of viral replication of viral life cycle. The virus can try to enter the cell, so there is an entry inhibitor, reverse transcriptase inhibitors, integrase inhibitors. And like this, it's a large group of drugs. The patient usually uses the treatment for life. And lastly, it's important to know the chemoprophylaxis against pneumocystic carinii, which causes a fatal pneumonia in these patients. Thank you for your listening. I am Dr. Khaled Al-Nahas. It was an honor to present this lecture to you. Thanks for all and good luck. Thank you.